Awesome. Welcome, everyone. Thank you so much for joining us today, back for another session with Pre-Health Shadowing. My name is Nina, and I'm the founder and CEO of PHS. Pre-Health Shadowing is a federally recognized nonprofit organization focused on creating flexible and accessible learning opportunities for pre-health students during the ongoing COVID-19 pandemic. So thank you all for being here. We are excited to bring another professional to spotlight today. And so before we get into that, I just want to let everyone know that we do have closed captions. This is to accommodate students of all needs and abilities. And so if you have any ideas about how we can be more accessible as a remote platform, please email us at info@prehealthshadowing.com. Additionally, if you would like to sign up for our email list, you can do so on our website, prehealthshadowing.com. If you want to make sure that all of your emails miss the spam, the junk folder, and the promotions box, you can save Pre-Health Shadowing as a contact to your email, and then it'll send directly to your inbox. So you can always get virtual shadowing sessions to your inbox. Additionally, if you want to stay in the loop with PHS, you can follow us on social media. At Pre-Health Shadowing, TikTok at Pre-Health Shadowing, Facebook at Pre-Health Shadowing. So be sure to stay up on that so you can never miss the session. Since we are a program that serves students worldwide, I'm interested in learning where you're calling from today. I am calling from California in the United States. SoCal, let me know where it's at, everyone. Feel free to drop it in the chat. Awesome. Well, if you are interested in being a part of the Pre-Health Shadowing team, we are currently recruiting for our volunteer team as well as our leadership team. So if you want to get involved, this is a great opportunity during the ongoing pandemic because you can create your own schedule and it's also 100% remote. So this would be great for anybody that is looking for that type of flexibility, looking to create connections with like-minded peers across the US and in other countries. If you're interested in learning more, feel free to stick around at the end of our virtual shadowing session today. We do have 3 team members joining from the Pre-Health Shadowing team, including myself, Emma, and Georgia, and so we'll be able to answer any questions that you may have about joining the team. We have a lot of different roles available. This is what our application looks like on the website. So if you're interested, it doesn't have to be, pre-health focused at all. If you have any other passions that you're looking to further explore that can also help you advance in your career, definitely take a look at the opportunities that we have. Additionally, if you are a high school student, we also have opportunities for you as well. We are working to establish pre-health shadowing as a club on various high school campuses around the US. So you can sign up on our website, prehealthshadowing.com/join our team. If you're looking to get published, Pre-Health Shadowing has articles, reflections, reviews, and success stories available for featuring. We like to feature various students of the Pre-Health Shadowing community, so be sure to check out our website, prehealthshadowing.com/blog submissions. We humbly ask that if you are able to donate today, please do. Please scan this QR code and share with your friends, your family, and your community. Pre-Health Shadowing is a student-run nonprofit organization that is providing free opportunities to students of any education level, any healthcare interests. And so please help us help you and help the students all over the world. We could not do this without the time and energy of our volunteers, and we humbly ask for you to share our mission with anyone who is interested. Throughout the virtual shadowing session today, I invite you to type your questions in the chat. Emma, our co-host, will be reading those questions at the end, which will be the Q&A portion of today's virtual shadowing session. So take advantage of this opportunity where we get to meet with our professional. Additionally, I encourage everyone to take good notes because if you're looking to get a digital certificate to verify your hours, we will have a post-shadowing assessment, which we will talk about more at the end of the virtual shadowing session today. So stick around. I encourage you guys to, keep track of your shadowing hours. This is a great way to do so. If you are able to, please turn your camera on. It's always great to see the wonderful faces that make up the pre-health shadowing community, and it's so much more fun than talking to a bunch of little boxes. So we definitely encourage you to do so. Of course, not always possible, so we completely understand. Without further ado, I would like to welcome to you our professional today. Welcome, Dr. Christine O'Day. Thank you so much for joining us today. It's an honor to have you.
Thank you so much for inviting me. And it's great to see so many folks from all over the country and around the world. So thank you for having me. I'm going to go ahead and share my screen if that's okay.
Yes.
Can you all see my screen there?
Yeah, it looks perfect. Thank you.
Awesome. All righty. So I am actually coming to you from Cincinnati. I am a faculty member in the Department of Family and Community Medicine here at the University of Cincinnati. And so thanks again for having me. Happy Cinco de Mayo. So I'm going to share a little bit about myself through and what I do. I am super passionate about family medicine, and I probably was not as smart as all of you when I chose family medicine, because I just didn't quite know what med school was about before I went to med school. But I am very happily super feel very fulfilled in my current role and love my job. So I'm happy to share a little bit about what I do and answer your questions, but I'd love to hear a little bit more about you all in the chat. So if you're able to share a little bit about where you're at in school, in terms of, well, are you in school? If so, where are you at in school? Like what year? And are you all undergrads, or kind of where are you at? I'd love to hear what you're studying and what your interests are. So if you don't mind kind of sharing that, I'll keep a look. So somebody's a senior. CU, Colorado University. McMaster's awesome in Canada. Stanford, biology. Awesome. Well, I love seeing that. So thank you so much for sharing that. It looks like we have a couple other Midwesterners here. So that's nice. Awesome. Thank you. So first of all, I just kind of wanted to hear how you would define family medicine, and what comes to mind when you think about family medicine. You're welcome to unmute yourself and share, or just go ahead and share in the chat. How do you define and what do you think of family medicine?
Who do we? It's kind of taking care of everybody in a family, like from infants to the oldest people.
Yeah, exactly.
Kind of a little bit of everything.
Yeah, so we take care of all age ranges from cradle to grave, so to speak. Everyone from infants to elderly and geriatrics. And yeah, we do see patients who are members of a family, which is wonderful and something I love. I have patients who are multiple generations. I take care of the little kids who are 4, and the parents and the grandparents and the in-laws. And so that's really fun. And it just gives such a different perspective when you know the whole family, right? And I see somebody said maintaining the health of all individuals within a family. So I think that health maintenance is so important too, or thinking about prevention. So we take care of not just illnesses and treating patients and their their disease processes, but certainly we think of patients as whole people, and we really focus a lot on prevention as well. So, and wonderful, so one of your family doctors helped you throughout your lifespan. Yeah, so that's great. So we provide primary care. So primary care, as you probably know, means we're like kind of the first stop. So when someone has a health concern, we're hopefully their first stop, as opposed to going to, say, straight to a specialist. Patients come in with kind of undifferentiated problems, and we are their first stop. And we take care of, as we mentioned, everyone from infants to elderly, and that also includes the care of pregnant women and providing prenatal care. In general, we have a focus on outpatient medicine. However, there are certainly a lot of family docs who do inpatient medicine, and some who do just inpatient medicine. But in general, our training is probably a little bit more focused on outpatient medicine. One of the things I love about family medicine is that it's just so flexible. And so throughout my career, I've been able to kind of flex and change the scope of my practice based on what the needs of the community were. And so we do have that focus on community health and serving the community. So for example, early in my career, I was needed to provide inpatient medicine and nursing home care. So not only did I see patients as an outpatient, but I also saw patients in the hospital, and that included taking care of them in the ICU. And then that included going to the nursing home as well. Then when I moved to overseas and I was needed to provide maternity care and attend deliveries, I was able to do that as well. So I love how it's super flexible. There are tons of fellowships available for people in family medicine. So in general, we're considered generalists, right? However, many family physicians do tend to focus on certain areas. And so if you're really interested in, say, geriatrics, you can focus as a family doctor on geriatrics, or sports medicine, or women's health. For me, global health is one of my passions. And so I've been able to kind of focus on that, as well as care of people who are underserved or underprivileged. So for me, that's been great. Lots of people have other interests. And so you can do a fellowship in certain areas if you'd like. You can also flex in terms of working out in the community versus working in an academic setting. I'm fortunate I'm able to do both. I have a clinical site that is out in the community, but I am in an academic department as well. And some people tend to focus on one or not one kind of area as well. And so for me, I really do a lot more adult care currently, and less peds, with a little bit of prenatal care. And then some of our family physicians provide maternity care and attend deliveries. So it's just a huge scope of care, which is amazing. I think I'm just going to take a break and make sure that can everybody hear me okay? Looks like there are some people with sound issues. Are you okay? Can you hear me? Okay, great. And again, I mentioned, I swear I never work from home. When I do, they always are mowing their lawn. So is that bothering y'all, the lawn guy? We're okay, okay. So how does one become a family physician? First of all, you would, after your undergraduate degree in the US, you would, or this is how it works in the United States. If you're outside of the US, I'm not as sure. I would have to defer on that one. In the US, after undergraduate, you apply to MD or DO school. And then you would attend a residency. That is, most residencies are currently 3 years. I think there's a couple residencies that are moving to 4 years, but currently most are 3-year residencies. Your residency really kind of focuses on, as I mentioned, a lot of outpatient medicine, but there definitely is training on inpatient medicine, as well as maternity care, and preventive medicine. And then you rotate in a number of different areas, including specialties like cardiology, orthopedics. You do an ICU rotation, peds, a lot of GYN, community health, and population health as well. So I wanted to share a little bit about my journey, just because I think it is kind of helpful from the standpoint to get a sense of the different things that you can do with family medicine. So I started out, I'm originally from Minnesota, and didn't really know what I wanted to do too much throughout high school, but thought maybe I'd be interested in being a physician. And so I ended up at the University of Dayton in Dayton, Ohio, where I got my degree, my undergraduate degree in biology with minors in religion and international studies. I spent a lot of time in undergraduate exploring a lot of different things. I changed my major many times throughout my undergraduate degree. But some personal experiences with my family members with serious illnesses really kind of led me to med school. And so I went back to Minnesota for medical school at Mayo. And throughout my medical school training, I was really pretty led and focused on family medicine. And as I spent time in med school, it was really apparent to me that family medicine was kind of where my heart laid. And so I went to residency here at the University of Cincinnati for a number of reasons, but global health was really important to me. And at the time, back in the year 2000, very few family medicine residencies were doing global health, and UC was one of those. And so that's what brought me here. After residency, while I was really excited about doing global health, I actually had a baby during residency, and then I was pregnant when I graduated from residency. So it really wasn't a good time to work abroad when I graduated. So I ended up taking a year off to spend time with my babies, and then moved to northern Wisconsin, and was a small town family doctor for 5 years before moving to Honduras as a full-time volunteer. After 2 years in Honduras as a full-time volunteer, working in a small clinic in Honduras, I came back to UC and joined the faculty. And over the last couple years, I was able to get my master's in public health right before the pandemic. I graduated. So that was good timing to finish up before the pandemic. So that's kind of been my overall journey. So why family medicine, and what kind of made me think about family medicine? As I thought about it in med school, I realized that my whole thought and idea of what a doctor was really was family medicine. I had been very active in service organizations throughout my time in undergraduate. And so I really wanted to learn how to integrate service into my career. And so I had some great role models for that in family medicine. And so I think that was certainly something that kind of motivated me to choose family medicine, was just that kind of those role models and that ability to serve within family medicine. So having been super active in service as an undergraduate, when I interviewed for med school, actually at UC, I interviewed with Dr. Fremont right here, and had an amazing med school interview with him, Dr. Fremont had worked in lots of homeless clinics and was just such a great role model for how you could serve as a family physician, and kind of opened my eyes to how that could function. And so he was kind of one of the first role models I had. Ended up not even coming here, although he became a role model later when I was a resident and a faculty member here. But then when I went to med school, Dr. Bachman was a family doctor who I met on the first day of med school, and became just such a great role model and mentor, who had just amazing relationships with his patients. And I would shadow him, and I was just always so impressed with how he knew patients for years and years and years, knew their entire family. And because of that, he was just so able to provide excellent, high quality care for the whole person, not just, for their physical complaint, but he really knew people well and could provide lots of care for their body, mind, and spirit. So to me, that was really important as well. I also had some experiences in med school working in a migrant health clinic. And so that was really transformative, and just showed me that that was another way that I could serve and use my medical training to kind of provide care to those who really needed it the most. And so those kind of experiences and role models were really important to me, and led me to family medicine. And frankly, it was an easy choice. It was kind of almost like a no-brainer to me. I didn't really have to think too hard. It was pretty obvious to me in med school what my residency and specialty would be in. So I mentioned a little bit about my journey. So one important thing is that after residency, I did take a year off, which was wonderful. I had a baby during that time, and another baby that was born in the middle of that year off. And that was a wonderful year off, and I cherished that time. I was also quite ready to go back to work after being a full-time stay-at-home mom to two little ones. And so after that year, our family moved to the North Woods of Wisconsin, and I was a small town family doctor, and really practiced pretty full spectrum family medicine. The only thing I really didn't do a lot of was I didn't do any deliveries. I saw prenatal patients, but I didn't do their deliveries. Other members of our group did that. And I was in a group of a number of surgeons. So most of the procedures in the group went to the surgeons. Some family doctors do a lot of procedures. That has never been a big part of my career. But I saw children, adults, in the outpatient setting, prenatal patients, as well as inpatient medicine as well, and ICU medicine, and then worked in the nursing home. I absolutely loved being a small town family doctor. I loved living in the community that I served, and going to church seeing patients around town, going to church with patients, just being a part of the community with my patients. And that was really, really special to me. And I'm happy to talk more about that if anybody's interested in that. It was just a wonderful experience. But I have to say that global health was always really important to me. And it was really something that always kind of called to me. And so after 5 years in Wisconsin, our family, and by that time I had 3 kids, and at the time then they were 5, 6, and 1.5. So our family moved to Santa Lucia, which is a small town of about 2,000 people in Western Honduras, and worked in a clinic and lived in a little boarding house right behind the clinic. So we lived there for 2 years. The clinic itself was kind of like a 24-hour urgent care, but the closest hospital was about 3 hours away. So we took care of a lot there. We did everything. So when a patient came in the middle of the night, we would run their labs, start their IV, we would draw their labs. We'd shoot their x-ray and read their x-ray, develop the x-ray and read the x-ray. We literally did everything. We'd do their deliveries. And sometimes if patients couldn't get to the hospital, we might keep folks for a day or two. So we did a lot in that little clinic. And we are quite busy there. That was a really transformative experience. Again, in some ways, very similar in some ways to my time in Wisconsin, because we were living in the same community that we were serving, which was really, really wonderful for me to be able to get to know that community. But after 2 years, it was time to bring my kids back to school. And so we moved to Cincinnati. And so in the last 12 years, I've had kind of a mixed role in Cincinnati of outpatient medicine, along with some administration and teaching and academic medicine. So I would say the focus for me has been care of patients who are underserved or underprivileged. And so I've done that in a number of ways. And that's what's great about family medicine, is there's just a lot of possibilities there. So not only providing clinical care, but also teaching residents and learners in order to inspire them and encourage them and prepare them to work with patients who are underserved. And then also been a part of kind of the administration. I spent 6 years as the medical director at our health center, and then kind of participated in different scholarship activities as well. So my clinical care has been at a federally qualified health center, teaching residents and med students. And then I serve as the director of global health education in the family medicine residency program, which includes travel to Guatemala twice a year. And then I'm the course director for medical Spanish, Latino Health Elective. So I teach medical students. I work in the community with the Latino Health Collaborative, advocating for improved health for our Latino immigrants. And then I serve as the associate chair for our family medicine department. So I wanted to kind of open it up. I've done a lot of talking, I'm sorry. I wanted to open it up and talk a little bit about FQHCs, or federally qualified health centers, or sometimes called community health centers. Does anybody know what I mean when I say FQHC or community health center? What is that? And feel free to unmute and share or put it in the chat. Has anyone ever worked in an FQHC? Or volunteered or shadowed? No? Okay. Well, then good. I'm glad we're talking about it. um, so a federally qualified health center, there's kind of four key pieces about community health centers. And oh, somebody worked in there. They focus on underserved populations and the homeless. Yeah, so in general, all FQHCs are in medically underserved areas as designated by the federal government. So that's the first most important thing. The FQHC where I work actually has 5 sites. Most of them are in the kind of inner city. One is in a suburb, but there's very few providers that accept Medicaid. And then another one is the other health center is actually out in a rural area. So community health centers can be in any area, except they have to be in a place that's medically underserved. So geographically, they could be anywhere, but it's in an area where there are few physicians or providers. They have to provide a comprehensive set of services, including primary care, as well as behavioral health, as well as dental and preventative health. They are open to everyone. I think that's a really important piece, that regardless of your insurance status or your ability to pay, they offer a sliding fee scale. So it doesn't mean they're free. They're not free clinics, but they offer a sliding scale. And then the other thing is that they all have a patient-led board. So they are kind of managed by local leaders who are also patients in the health center. And community health centers are just really amazing. They serve over 28 million people across the United States. And the majority of their patients are lower income. As you can see here, 91% of patients are low income. So the majority of them fall below 200% of the poverty level. And the majority of them are from racial and ethnic minority groups. As someone mentioned, they often serve homeless patients as well as veterans. So in my patient population that I have at my community health center that I work in, about 80% of our patients have Medicaid. About 10 to 20% of my patients then are uninsured completely, and then the rest are usually underinsured, and so they may have a high deductible or catastrophic type of insurance. So our patients are kind of universally disadvantaged. So what is a typical day for me? There's no typical day. My days are all very different. I'd love to talk about that. Maisha, your comment, let's talk about that afterwards. But this is kind of what my clinic day looked like on Friday.
Yes.
And so our patients, because they're experiencing so many barriers to care and dealing with so many other social determinants of health, such as difficulty with transportation, difficulty with food insecurity, because they're dealing with all that, we really need to have all those wraparound services. So that's one of the real benefits of working in an FQHC. One thing I love about working in the FQHC is just the diversity of my patient population. So I serve a lot of immigrants, particularly Latino immigrants. And so I had, a patient from Honduras who was pregnant, who came in for her prenatal care. Then I saw a preacher from the suburbs who came in for his high cholesterol and just a checkup, was worried because of a strong family history of heart disease. I saw another woman who has bipolar disorder and was coming in for a pre-op, and we're going to talk a little bit more about her. And then just a wide variety of patients that I see on any given day. So that for me is really exciting. A lot of chronic disease for me, a lot of diabetes, but also a lot of kind of prenatal care as well. So just to kind of circle back to what family physicians do, we manage a lot of acute issues. So at the peaks of COVID, we were seeing a lot of COVID and managing that in our clinical setting. Our patients come to us because community health centers are in the places where people live. People can walk to us. They can't get to the hospital or to some other site. So they came to us when they had symptoms. And so we were able to set up a separate area where we could see COVID patients. We manage a lot of chronic disease, diabetes, hypertension, depression, asthma, a lot of mental health issues that we manage. And then we provide lots of preventative services like immunization and lifestyle counseling about diet and exercise, and doing things like colon cancer screening, women's health services like encouraging mammograms and pap tests and things like that. And then we also do a lot of population management, where we look at our patient panel and we kind of reach out to those patients who are due for follow-up. So instead of just sitting in our office and waiting for patients to come to us, we reach out to them and say, gosh, we know that the last time you were here, your blood pressure was high and we haven't seen you since then. So we want to reach out to them and bring them in. I don't know, am I doing okay on time, Emma? Am I okay to keep going, or?
Yeah, you're doing just fine. Feel free to continue. Yeah, no worries.
So in addition to clinical care for myself, I do about half clinical care and the half other things. So as I mentioned, as an academic physician, I'm expected to participate in scholarship. And so for me, that has been mostly small research projects and presenting my work. And then I am part of our Center for Global Health Initiatives with the AFP board. From an administrative standpoint, as I mentioned, I spent 6 years as the medical director of our health center. So that meant kind of managing the quality of care that was delivered at our health center and kind of developing policies to maintain excellent quality of care. In the residency, I manage our partnership with the non-governmental organization Mayo Health Alliance in Guatemala. And then I also chair the Latino Health Collaborative, which is a group of individuals both in the community and in the academic health center that are interested in improving the health of Latino immigrants in Cincinnati. I also teach in the med school and in the residency on global health. And then I teach am the course director for medical Spanish in our med school. So I wear a number of hats like a lot of family physicians do. I wanted to share a little bit about our partnership with Mayo Health Alliance, or WUKUKUOK. So this is one of my hats, is to kind of help manage this partnership. We support Mayo Health Alliance, which is an amazing nonprofit down in Guatemala that provides culturally appropriate care to Guatemalans in the language of their choice. For the last 7 years, we have supported them through primary care services. We send groups now 5 times a year to Guatemala to provide primary care. And during the pandemic, we kind of flexed and moved to telehealth, but we are back in person again in Guatemala. So that's been a wonderful part of my job as well. This is a reminder. This is where I got left off, or I ran out of time, but I wanted to just kind of talk about global health and family medicine. So for me, family medicine has been a great avenue to participate and have a career in global health. As I mentioned, because it is so full spectrum and gives you so much flexibility, it really has been an ideal specialty to be involved in global health. Now, I definitely encourage folks who are interested in global health. It doesn't matter what specialty you're in, you can still participate and have an active career in global health. But I do think that family medicine is really uniquely positioned to be able to serve in the area of global health. I also love that as a family physician, I can be an advocate for my patients. And so since I moved back to Cincinnati, just my ability to be able to speak Spanish meant that a lot of immigrants found me, because for a lot of people, it's just so important to be able to see a physician who speaks their language. And so once the community knows you're there, they kind of find you. And so I just ended up with a lot of immigrants in my practice, which has been a really wonderful thing. And I love working with immigrants. Our immigrant community really has a lot of struggles and barriers to care, and I'm privileged to hear what they're going through when I see them. And so that does put me as a family physician in a really unique position to be able to share with policymakers and legislators and our community what our immigrant community is kind of facing. And so I think family physicians have a unique opportunity to be advocates for their patients, both individually as well as on the local, state, and national level. So I was going to share 2 cases, but I don't have to do that. So tell me how we're doing on time. Do you want me to share one of the cases? Should we open it up to questions? What would you like to do, Emma or Nina?
We generally run these sessions like an hour and a half. So if you want to keep going, I think around 2, we can start the Q&A, or before then if you're done by then. But I think you're totally fine for now.
Okay,
yeah,
awesome.
I'd love to hear the cases. Thank you.
Awesome. So these were just 2 of my patients that I saw last week that I thought were really interesting and kind of highlighted some real challenges for patients and ways that family medicine can make a difference. So this first patient is a 51-year-old female who's African-American, who I've seen for probably about 10 years, off and on. She doesn't come in very often. She frankly doesn't like to come in, and she tries to make her visits as short as possible. And she has severe psychiatric illness. She's co-managed by a psychiatrist, so I don't manage her bipolar and her intermittent explosive disorder. So the psychiatrist manages that, but I manage her other medical issues. She has what many of our patients in our inner city community, I would say in particular, have, and many patients within the African American community have kind of a distrust for the healthcare profession in general, and with good reason. For many patients, many of my patients will remind me about the Tuskegee syphilis studies that occurred. They'll remind me of many not so distant in the past episodes that they've had in the emergency room with racism. And so they have a general distrust of the healthcare profession. This woman has seen me for a long time. And while she doesn't like coming in to see me, because she generally would prefer to stay home and stay out of the clinic, she does come in, and she has a trust for me because we've developed this relationship over a long period of time. I ask that she comes in at least every 6 months for her high blood pressure. She usually stretches that out to like every 8 or 9 months. And she's always like, when she gets there, then she really is just like ready to go and wants to leave as soon as she comes in. I didn't see her much during the pandemic. She was very anxious during the pandemic and didn't want to leave the house at all. So she finally came in on January 7th for her checkup for hypertension. Her blood pressure was doing fine at that time. And so although she doesn't like to stay too long, I try to at least talk about 1 or 2 health maintenance issues each visit. And so we now encourage everyone over the age of 45 to get some type of colon cancer screening. There's a number of ways to do that. One is stool-based methods, where a patient would collect their stool and send it in for testing, looking for blood or other DNA markers that are related to cancer, such as that's what the Cologuard is. Or a colonoscopy, which is where we ask the patient to do a clean out of their colon, and then we put them to sleep, and then we pass a scope up their bottom to look for polyps. We know that colon polyps over time, over 4, 5, 6 years, will develop into cancer. And so if we can find those polyps before they turn into cancer, then hopefully we're preventing cancer or finding it at an early stage. So she agreed to do the Cologuard, and her Cologuard actually came back positive on January 27th. So I was pretty happy that she turned it in. We sent her then for a colonoscopy, and she in fact did have a adenocarcinoma of the colon. And I'm thinking about her, and I ask you to all send prayers and good vibes to her, because she's in surgery right now for that colon cancer. She's had a workup that included a CAT scan of her chest and her belly, and it appears that it has not spread. So it appears that we've caught it before it's gone anywhere. So I think this brings up some interesting and important points. One is that people who have serious mental health issues and serious psychiatric illnesses, and by that I mean bipolar and schizophrenia, they actually have significantly reduced life expectancy, and that is due to a lot of issues. One is that some of their health behaviors are not as healthy, so they're more likely to smoke, and they might be more likely to use alcohol and other drugs. But another issue is that they are just less likely to get in for health maintenance issues. And, I think the fact that this patient has a long-term relationship with a family physician, with a primary care physician, is so important, and that she was more likely to get screened. So while I'm sad that she had colon cancer, I'm really happy that she did get her screening turned in and we screened her. And it sounds like we've caught it early enough that she may need just surgery and no chemo or other treatments. So, so I think that's a win, that we found this early. Would it have been better if we found it earlier, where we could have just taken a polyp out and she didn't need surgery? Yes, but hopefully she'll do well moving forward. So the next patient I wanted to share with you is actually an immigrant from Guatemala. So Cincinnati is what we call a non-traditional immigration city. So some of you are from California or in Canada, where you're used to getting lots of immigrants. Cincinnati in the past was not a place where we had tons of immigrants, particularly Latino immigrants, but in the last 20 years, we've received more and more Latino immigrants. And so our social services kind of infrastructure was not necessarily ready for them. And so we're still kind of learning how to respond to our immigrants. So this patient is a 45-year-old immigrant from Guatemala. And he was presenting to establish care. So he really didn't have any concerns. He had actually never seen a physician before in his life. He had received like his immunizations as a kid in Guatemala, but had never had any other reason to go in. I'm friends with his pastor at his church, and his pastor has been a really big advocate for the COVID vaccine. And so when he has somebody that he really wants to get in for the COVID vaccine, he sends them in to see me. So he really kind of just came in for his COVID vaccine, and then also to be established. And this is also kind of an important point, is that for a lot of our immigrants, it is not part of their culture, where they their previous country, their home country, to have a primary care provider. So they often don't know that they need to establish when they move here. And so they end up just kind of going to the emergency room when they need care. And so one of the things we've really worked on in Cincinnati is to try to encourage the immigrant community to establish with a primary care provider, so that when they do get sick, they don't have to go to the emergency room and get a big bill. They can just come in and see their primary care provider. So his pastor has kind of passed that on to him, and so he came in to see me. So he didn't have any concerns. He felt fine, but he's fairly recently arrived. And so we recommend some screening labs for our immigrant patients. I wanted to kind of just open that up to you all. If you were seeing immigrants coming into your clinic, what kind of things would you be concerned about and would you want to screen for? And again, I will just open it up in the chat, and also feel free to unmute. What would be some things you'd be concerned or worried about? Awesome. Wonderful. Okay. So yes, insurance. So many of our immigrants in Cincinnati, well, I would say, excuse me, many of the immigrants that are in my clinic are undocumented. And so they do not qualify for insurance. Many who come in as with refugee status, they will have Medicaid for 6 months, and then they get 6 months of Medicaid, then they have to either get a job or they're uninsured. So a lot of what we do is kind of explaining how the insurance or payment system works. So for this patient who was undocumented, we just explained that there's a sliding scale and that he, for most of the patients, that means they pay about $15 per visit. And that includes everything that they get during that visit, immunizations, labs, and their visit. So good question about insurance and payment. That is definitely kind of a topic of education. And a lot of these visits are education about, like, this is how the healthcare system works. So that's for all of our patients, not just immigrants, but especially important for immigrants. Test for TB. Yes, thank you. Great one. This patient did get tested for TB. There's a couple ways to do that. You all might have had the skin test called the PPD that requires the patient to come back in 48 to 72 hours. And people don't like doing that. We can't get people to come back. So now we have a quantiferin gold blood test that we do. I did do that for this patient. And in fact, that patient did come back positive. So he had no symptoms. He had no cough, weight loss, anything like that, fevers, nothing like that. But he does have what we call latent TB. So his chest x-ray was negative. And so latent TB means that he has been exposed to someone in the past that had TB, and he has TB that is dormant and can reactivate in the future if he gets sick, if he is immunocompromised, say he gets HIV, say he gets cancer, goes on steroids, whatever, it can reactivate and become active. And so we do recommend treatment. So I have referred this gentleman to the TB clinic to get treatment for latent TB. So good thought and good response. Thank you. Making sure his immunizations are up to date. Yes, that's so important. Would be wonderful if I could find vaccination records on most of these patients, but usually we can't. And so we do kind of get them all tuned up with their vaccinations. Yes, that's very important. Full lab workup. Yes. I love this. Wonderful. Great job. So yes, for this gentleman, we did do a lot of labs for him. And so I think, so there's basically 3 labs I kind of do for all immigrants from low or middle income countries. And then I really kind of base it on where they came from and what diseases are common in that country, as I think one of you all mentioned. So, so for this gentleman coming from Central America, we screened him for tuberculosis, as you all mentioned already. And then I did a CBC, and that's a complete blood count. So that also includes a differential looking at all the different types of the white blood cells. And then I did an HIV. So those are the things I do pretty much for everybody. If they're coming from certain areas of the world, so from certain African countries, we look for schistosomiasis, which is a parasite in the bladder. For certain Asian countries, we're looking for hepatitis. So it kind of just depends where they're coming from. For our Latin American countries, I kind of do those 3, CBC, HIV, and TB. So we already mentioned that his TB test came back positive and what we're doing for him there. His CBC came back positive for eosinophilia. And so eosinophils are a type of white blood cell that can be high in particular illnesses, but in particular for immigrants, we are looking for things like parasites. And so it can be high in folks who have parasites. Now, a lot of parasites will just kind of burn themselves out and will go away on their own. But there's some parasites that don't, and things that we really worry about. So his eosinophil count was high. So I asked him to bring in a stool, ova and parasite, so looking for GI parasites. And then I did some blood tests on him. I looked for strongyloides, which is a type of roundworm, as well as Chagas disease, also called American trypanosomiasis, which is also another parasite. And he, in fact, had a positive strongyloides. His OMP was negative, the ova and parasite, and the Chagas serology was negative. However, his strongyloides was positive. And so strongyloides, I feel like I can't have a talk without including one of these CDC life cycles of these worms. But again, this is a type of roundworm that actually lives in the soil. And for people who walk around without shoes on, the worm can actually go up through their feet and then can kind of continue to auto-infect. So it travels up to the intestine and then lives in the intestine and then just kind of auto-infects, and person can hold strongyloides in their system for years and years and years. The thing that we worry about with strongyloides is that it can be similar to TB. It can flare up and cause a fulminant infection years later. And so say this gentleman again gets HIV or gets cancer and undergoes chemotherapy. Perhaps he gets TB and he's immunosuppressed. He can then, the strongyloides can become fulminant and can spread everywhere, and he can become extremely sick and die quickly from the strongyloides. So it's one of those worms that we want to catch and we want to treat. So this gentleman came in just to kind of get checked out. We did give him his a couple immunizations, including his COVID vaccine, as well as his and his tetanus shot. But we also found that he had both latent TB and strongyloides, so we treated them for that. So it was a good thing he came in. We also, you are totally correct. We also do a screening for a gentleman like this, and we check for, we do a lot of screening. So we check for depression. So we screen everyone for depression, and depression can be really common in this group. And so we definitely check for that. We check for alcohol use and other drug use. We would recommend that he gets colon cancer screening. We checked his blood pressure, that was normal, and we checked his cholesterol and his liver enzymes as well. So good job. You guys did you guys would take care of our immigrants well. Great job. I think you, I also think we did some STD screening on him as well. And somebody mentioned our undocumented immigrants concerned or scared to come to a physician due to their immigration status? Yes, that's definitely can be a concern. And so that's why it's so important that we are out in the community kind of offering education. And that brings up another great point that I think is an important thing that we do as physicians, and in particular as family physicians, is that community education. And something I feel strongly about is that we can't just sit in our clinics and wait for people to come to us, but we have to be out in the community. So last weekend I was out at a health fair, and that's one of the things that I love doing. I love being out there and educating people that it's safe to come to the doctor, and that we welcome everyone, and that it's we're not going to report anyone. And in fact, I mentioned that this gentleman was undocumented, that I don't actually ask specifically about that. It might come up for reasons like we try to see if everybody can get on insurance if they can. So if somebody doesn't have insurance, we try to make sure that they get on insurance. And in the course of that discussion, it may come up that they're undocumented, but it's not really a standard question I have, like, are you documented? I don't ask that question. It's just one of those things that might come up. But yes, that can definitely be an issue for sure. So I think that's all I have for you prepared, but I'm happy to answer any other questions you have. And then that's my email address as well, in case you want to email me with any questions as well. I'm going to actually stop sharing so you don't have to look at that anymore. And I can put my email address in the chat if you didn't see that.
Sounds good. So I wrote down some of the questions from the audience during the session. I'll just start from the top, if that's okay, and we'll see what we can get through. Just more of a general one, but something I'm sure we're curious about. Someone asked, what was your favorite or most memorable rotation in your residency?
Yeah, good question. So I was pregnant during most of residency. And so a lot of particulars of residency I don't remember. And it was a long time ago too. It was 22 years ago. But I would say that my global health rotations made a huge impact on me. So part of our residency was and continues to be our relationship with underserved communities in rural Central America. So when I was a resident, I had 2 rotations in Honduras, which obviously I loved and made a big impact on me from the standpoint that I didn't want to just go for 2 weeks. I wanted to be there long term. And so that's kind of what motivated me to go back long term for 2 years. So I would say that was one of my most favorite rotations. But like most family physicians, when you ask us, what's your favorite rotation in med school or in residency, we love it all. And a lot of us go into family medicine because in med school, we love everything. We love peds, we love internal medicine, we love the hospital and inpatient, we love it all. And so we can't decide. And so we go into family medicine because we can do a lot of that. So I would say that I liked it all.
I like that. And that's a good point, because I've thought about that if I end up going PA, like the plan, I'm so indecisive and it's all interesting to me. So I really like that perspective. Let's see. Okay. Leah asked, how does one get started in global health if they're interested?
Yeah, that's a great question. I think there's lots of opportunities now in undergraduate institutions as well as med schools and residencies to participate in global health activities. And so I would just encourage you to, first of all, if you can volunteer abroad for a good organization, that's probably the best way to get involved. But before you do that, make sure that you do your homework on the organization that you work with and make sure that it's a good organization doing good work. That's like almost like a whole nother pre-health shadowing discussion, which I'd be happy to do about how to do that. But I think the first question you want to ask yourself is like, why am I interested? What piece of this am I interested in doing? And am I qualified to do that? And if that's the case, then trying to find an organization that's doing that really well and finding a way to get involved with that organization. So I know at UC and at, or, you know, undergrads throughout the country, there's different organizations involved with global health. I know we have at UC Globe Med, we have a Partners in Health student organization. And then there are lots of classes. I think most undergraduate institutions now have a global health class, undergraduate classes, as well as master's levels classes. So I would encourage you to start looking at some of the organizations at your school or some of the courses at your school.
I'm going to combine these two questions kind of because I feel like maybe they could go hand in hand. Sonia asked earlier, what made you decide to volunteer in Honduras? And then additionally, we just got from Lexi a question, how difficult was it to go volunteer for 2 years logistically? Was it difficult for your family? And then maybe like monetarily wise, work-life balance, all that?
Yeah. So working abroad was kind of something that I had felt called to do for a long time, probably since high school. And I didn't always know what that looked like, but I did some rotations in Central America as a med student and as a resident, as I mentioned, and felt like, well, 2 weeks was a good experience for me. I didn't feel like it was as really very beneficial for the community. And I felt like for the community to really be able to make an impact, you had to be in a place long term. And so that was motivating for me. I'd also felt, you know, for my life, I've been very fortunate. I've been very blessed in my life. And I felt like it was a time that I could give back. Having said that, I feel like I probably gained more than the community that I was at. I mean, I feel like I learned so much during that time, and it was such a personally fulfilling and rewarding experience that it was just life-changing and career shaping for me to spend that time abroad. Is it logistically challenging? Absolutely. I mean, I had 3 kids under the age of 6, and just working with 3 kids under the age of 6 is logistically challenging anywhere, let alone in rural Honduras. And so we went to, we moved to Guatemala and lived in Antigua for 2 months to kind of get our Spanish up to par before moving to the rural site where we were at. And then I homeschooled the kids in the afternoon, and yeah, it was logistically challenging. We had to make sure all of our loans were paid off before we went. And financially, in order to raise the funds to go, we sent letters to all of our friends and family, and told them what we wanted to do, and said we needed to raise $60,000 to do it. And we were very blessed. We raised that money pretty quickly and easily. So it was challenging, but it was worth every minute of it. It was a wonderful experience, and I still feel very connected and close to that community in Honduras. They still call me and email me and WhatsApp me, and so I think it was a wonderful experience. I wish more people did that. I think that it also, as you can tell, that experience really allowed me to provide much better care for my patients here. So I wasn't quite ready to come home, but it was time to come home for my family. And so when I moved back, I was like, gosh, if I can't take care of Hondurans in Honduras, maybe I can work with Hondurans in Cincinnati. And that's kind of what happened. And it does really allow me to provide better care and to relate to my patients well, so that, I understand the culture a bit, and I can understand where they come from, and I can speak their language. And so I feel like because of that, I'm able to provide a little bit better care for them. And I have a good relationship with my immigrant patients. So it was an incredible experience, and I highly recommend it.
Amazing. Next question. Alan asked, when working at FQHCs, are the majority of visits repeating patients?
That is an excellent question, Alan. I would say, well, here, I can tell you that our FQHC is considered a medium-sized FQHC, and we have about 40,000 patient visits per year, and we have 12,000 unique patients. So that should give you a good sense that most people must come back more than once. I mean, I would say for me, since I've been there 12 years, the majority of my patients I've seen before. I'm still seeing new patients. I saw a new police officer today. He came in as 55-year-old and hadn't seen a doctor in 15 years. So that happens, that I have new patients, but the majority of my patients I've seen for a long time. And that's just so fun. That's what makes family medicine for me so wonderful, is that I have known these people for a long time, and I know their families, and so that relationship is so important and very rewarding.
Okay, and then Kimberly asked, in your view or opinion, what programs have you seen or that you can think of have been implemented for minority health to help alleviate many health disparities that plague the minority community, such as just being treated equally and fairly?
Yeah, that's a great question. I mean, I think there's so many layers to that, right? One is recruiting and training and inspiring members of the community to be healthcare providers, right? So patients prefer, and patients, it's been shown, receive better care when their provider looks like them, whether that's racial or ethnicity. They get better care. and that would go for language as well. You know, that if a patient is Spanish speaking, they're going to receive and get better care from a provider that's has language concordance, right? So I think our efforts to recruit underrepresented minorities in medicine are really important. So I would say that's one. Two is just the FQHC and the community health center movement. And I did want to comment on Maisha, who says FQHC should be a concept globally. That community health center is actually the kind of the basis for community health centers comes out of community-oriented primary care, or COPC, which comes out of South Africa and the CARCs. So I would encourage you to Google community-oriented primary care. And that's where it comes out of, the CARCs that lived in South Africa and developed this concept that people should be able to go to a health center where they live. So I think that community health centers do a great job at promoting health equity, because we are in the communities where people live, and people feel comfortable coming to us. And then we address those social determinants of health. So I would say the third thing in that piece of how do we kind of promote health equity is through addressing social determinants of health. So, you know, my patients, for example, my immigrant patients, they might have a lot of trouble with transportation. And so I think I mentioned on Friday, I saw the patient with, she was pregnant and she has high blood pressure, and she kept missing her appointments because of she didn't have her husband home to take her to the doctor. And so she missed another appointment. And I called her. I was like, you have to come in. You have high blood pressure. I need to see you. And we sent an Uber for her. And she actually got induced and got a cesarean last night because she had high blood pressure and needed to be induced. So addressing transportation and food insecurity issues and housing insecurity. So a lot of FQHCs now are screening for social determinants. So that means that the patients get a screening questionnaire asking about all of the social determinants of health that hopefully you're learning about, all those things outside of the medical care that patients receive, all those things that affect health, where we work, live, and play. So housing, food, transportation, documentation status, race, ethnicity, all those things affect our health, probably more than the medical care we receive, definitely more than the medical care we receive. And so how do we address those? So we screen all of our patients and then try to connect them with resources. So do you have trouble with food? Do you have housing issues? And if they do, then we by zip code can give them kind of a list of resources, here's a list of food banks near your house. Say you're having trouble with unsanitary housing conditions because your landlord is a deadbeat. Here's the the phone number for legal aid. This is who you call to get that addressed. Those kind of things I think can really help address health disparities as well. But we have a long way to go. We really do. Good question.
Yeah, I appreciate that answer. And whoever asked that, I think is Kimberly. I appreciated that too. And yeah, we have a long way to go, of course, but yeah, if we just hopefully, working on programs like that and being able to do that with FQHCs and beyond, honestly. And then we'll just do one more question before wrapping up. This is more shifting back towards family medicine and just your personal work. Sonia asked, do you have a favorite type of patient to treat, or what do you find most interesting and what do you find most difficult in family medicine?
Like most things, I would answer the same to both of those questions. So I think what's most interesting is just the variety, but what's most challenging is the variety, so maybe as family doctors, we get bored easily. I don't like, that's why we went into family medicine, because we don't want to be bored and we see such a wide variety of things. And so that makes it so interesting. And for me, like, I love that it's not just that it's a wide variety of quote problems, like patients with different issues. It's that my patients come from all over the world, that they come from so many different backgrounds. That I find that really interesting. But it can be stressful, just that there's such a huge range of topics that we need to stay up to date on. And fortunately, as one of our chair says, medicine is open book. So you all can relate to that in school. That, when I'm seeing a patient, I look things up all the time, and I tell people I'm doing that. And I really have to be very clear with my patients about what my boundaries are in terms of what I know and what I don't know. I'll say, like, gosh, that you really need an insulin pump, and that's not in my wheelhouse. I need to refer you to endocrine. Or I need to be able to know exactly where my boundaries are and be able to ask for help when I don't know something. And so I think that can be sometimes challenging, but I think now I pretty much know what I can handle and what I can't. And I have a good network of folks that I can reach out to when I need help. And so I think that's really important, but those can definitely be challenges in family medicine.
Wonderful. Thank you so much, Dr. O'Day, for joining us today. It was an absolute honor being able to hear about your journey and what you've gotten from this. And so as we wrap up today, I just wanted to thank you for joining us, and all of our students. If you have any personalized thank yous, feel free to throw those in the chat. For any of our students joining us today, I encourage everyone to reflect on today's session. What really brought you here? What are 3 major takeaways that you got from today's session? And what do you want to learn more about? Dr. O'Day was extremely kind to put her email and make that available to you. So if you have any questions, feel free to reach out and connect with our professional here today. That being said, if you are looking to get published on the Pre-Health Shadowing official website, feel free to submit your reflections from today's virtual shadowing session to prehealthshadowing.com/blog submissions. We would love to hear more about your inspiration, what brought you to healthcare, to pursuing this pathway, as well as taking the stories that you hear from our professionals and applying that to your life. So we'd love to hear about that. If you're interested, these are great for your resumes, applications, and you can put this on your LinkedIn profile. Always great. As I mentioned at the beginning of the virtual shadowing session, if you are interested in being a part of our nonprofit organization, we are recruiting individuals to join our volunteer team and our leadership team. If you'd like to be a part of fighting inequity in health education and promoting diversity in the various healthcare fields, this is your chance. You can register on our website, and there's an application form if you're interested in joining as a team member. If you're interested in volunteering your time, as I mentioned, you can do this 100% remotely. You can create your own schedule, and you can connect with a bunch of really amazing people in different parts of the world. If you are able to donate, please scan this QR code. If you're financially unable to donate at this time, we do ask that you share this QR code with members of your community, your family, and your friends. We do run solely off the time and donations of our volunteers and are working to keep pre-health shadowing free, accessible, and open to anyone who is interested. So help us support our mission of creating flexible and accessible opportunities for students by supporting our nonprofit. Now, the moment you've all been waiting for, how to earn your digital certificate. So you can go to the pre-health shadowing website and click on Dr. O'Day's page. From there, you'll be able to take the quiz, which is our post-shadowing assessment. You will have 10 questions that are not meant to be particularly difficult, but if you were able to take good notes throughout the duration of today's session, you should be able to answer those. You'll have 2 tries and 30 minutes to get a 70% or higher on the virtual shadowing, post-shadowing assessment. Once you do so, you're able to download your virtual certificate immediately. I recommend that you save this to your computer or your files as soon as you get it, so you can retrieve them at a later time. If you missed any part of today's session, it will be available on our YouTube channel as well as our website, where you can watch any of our past sessions as well. So if you're interested in learning more about different careers, different specialties, and different journeys that our professionals have gone through, I encourage you to check out the pre-health shadowing website. Be sure to catch our sessions every week. We have an amazing lineup for you. You can follow us on social media as well as stay posted on our website. Check it often. There's updates going on all the time. That is all for today. Thank you everyone for joining the pre-health shadowing virtual shadowing session today. And thank you again to Dr. O'Day for sharing your amazing journey with us. It was an absolute honor to have you.
Thank you. You guys do a great job, and best of luck to everybody.
Thank you. Have a great rest of your week.
Take care.
Bye-bye. And if there's any students that are interested in learning more about joining the pre-health shadowing team, volunteer team, any questions about our organization, feel free. I'll go ahead and stick around to answer any of those questions. If not, that is the end, and you are welcome to leave the Zoom.